Hello there. My name is Tjun Tang. I'm one of the vascular surgeons from the Department of Vascular Surgery at Singapore General Hospital in Singapore. I shall be presenting our world's first experience treating TASC II C D tibial occlusive disease using the solution sustained limus release drug-eluting balloon, and these are 12-month results. These are my disclosures relevant to this talk. So the PRESTIGE trial is a physician-initiated, prospective, non-randomized, single-center trial investigating the safety and efficacy of the treatment with the solution sirolimus-coated balloon in TASC C D tibial occlusive disease in patients with critical limb ischemia from Singapore. So as a background, the solution SLR balloon is a novel sirolimus-coated balloon with what we call proprietary micro-reservoir technology. Basically, the sirolimus is coated with biodegradable polymer and put into these micro-reservoirs. And why we're going down the sirolimus route is probably because it offers potentially a wider therapeutic range, and it's proven to be probably safer and a more effective cytostatic drug than paclitaxel to minimize the risk of restenosis. These micro-reservoirs basically have a sustained therapeutic effect to 90 days, and this has been shown in preclinical animal models. And with those micro-reservoirs, we use cell-adherent technology. This is basically amphipathic lipid technology that allows these micro-reservoirs to maximize cellular uptake of sirolimus into the arterial wall. And the balloon has a drug concentration of 1 microgram per millimeter squared. So these are the endpoints of interest from PRESTIGE. We looked at freedom from device or procedure-related mortality through 30 days, freedom from target lesion revascularization at both 6 months and at 12 months. And this was defined as any clinical reintervention performed for more than or the same as 50% diameter stenosis of the target lesion on duplex. We looked at freedom from major target limb amputation, target lesion primary patency rates at both the 6 and 12-month time points post-study procedure. We also looked at technical success rate, which was defined as able to cross and dilate the lesion to achieve less than 30% residual stenosis. Clinical success was defined as improvement of the Rutherford score at follow-up. And we also looked at wound healing, which is obviously pertinent to the setting of critical limb ischemia. And this was basically defined as a complete closure of the wound or more than 70% healed at those time points. These were our inclusion criteria. We looked at both de novo and restenotic lesions located specifically in the tibial arteries. These had to be complex lesions, more than 10 centimeters in length, either TASC C or TASC D in nature. There had to be at least an angiographic evidence of a stenosis of more than 50% or occlusion in that vessel. You had to cross the lesion with a standard guide wire and predilate to less than 30% residual stenosis. Safaris were allowed. Target vessel diameters had to be between 1.5 millimeters to less than 4.5 millimeters because of the balloons available, and this was by visual estimation. And any tibial vessel that was intervened on must have a distal reconstitution above the ankle. We treated the inflow lesions, if there were any, in the iliac, SFA, and popliteal with conventional balloon angioplasty, and this had to be optimized to less than 30% residual stenosis and no evidence of embolization before we could get on and deal with the BTK vessels. And there had to be at least one vessel runoff or main vessel runoff through the ankle and into the foot. This was the post-op follow-up. We reviewed the wound at both 1 month, and then we looked at that 3 months, 6 months, and 12 months. And at those respective time points, we used the walking impairment questionnaire and a quality of life questionnaire, EQ5D, and we did duplexes at both the 6 and 12-month time points. So turning to results, these were our demographics. As you can see, this is a complex, frail population of patients. You can see the diabetic rate is over nearly 90%. End-stage renal failure, i.e. being on dialysis of either PD or HD, was 44%. All patients had a wound of some degree, and all of them were Rutherford 5 in nature. At least 56% of these patients had a moderate or high risk based on the Wi-Fi score for major lower limb amputation. You can see, turning to procedural characteristics on what happened, did not require any bailout stenting. The anterior tibial artery was the most treated vessel. And in nearly 2/3 of these patients, the lesions had moderate to severe calcification. So this was the 6-month data. Technical success rate was 100%. Freedom from device or procedure-related mortality through 30 days was 100%. Freedom from target lesion revascularization was nearly 93%. Amputation-free survival was around 84%, with 3 deaths and 1 major lower limb amputation. Target lesion primary patency rate was about 82%, and the wound healing rate was quite admirable at this time point of nearly 82%. Now, this is the slide of interest for this talk. You can see that the values for the same endpoints, freedom from target lesion revascularization, amputation-free survival, target lesion primary patency, and wound healing, are all sustained at 12 months, very similar to what was seen at 6 months. Turning to clinical success, using the Rutherford classification, you can see that there was a significant improvement in the Rutherford score at baseline, from baseline to 6 and 12 months. And you can see at least 80% of these patients showed an improvement by 1 Rutherford category by 6 months. And this again is sustained at 12 months. This is an example of a case study from Prestige, a difficult lesion here, where the wound is actually on the heel, an even more difficult place for a wound to heal, mind the pun. And you can see from the pre-PTA angio that there is a long ATA occlusion starting from near the origin. And we managed to cross this from an antegrade approach. You can see there's a lot of distal disease, even in the dorsalis pedis artery, and basically inframalleolar disease accounted for nearly 20% of these cases. We managed to open that up with a high pressure non-compliant balloon, and then we drugged this with the solution SLR balloon. And we used a 2.5 millimeter balloon at the bottom end and 2 3-millimeter balloons at the top end. And you can see the follow-up duplex, it's showing a biphasic signal in the ATA at 6 months, and at 12 months, the vessel remains open. And the wound, looking at the timeline, is healed at 12 months. In fact, even at nearly 6 months, the wound was healed, and it remained healed at 12 months. So in conclusion, ladies and gentlemen, the SGH experience using the solution SLR balloon is positive. There was no issue following a usual 1-to-1 Hobart to DEB sizing, and even using a DEB of 0.5 millimeters bigger was not an issue. The balloon tracks well on a 0.18 platform, and there's a short inflation and deflation times. There is excellent visual markers to place the balloon accurately. The device is safe. There were no serious adverse events using it through 30 days. We also noticed that there was minimal slow flow phenomena after even treating the inframalleolar lesions, and typically you do get a minimum slow flow phenomenon using paclitaxel-based platforms. The primary patency rate is admirable, nearly 78% at 12 months, an amputation-free survival of nearly 84%, and a freedom from TLR of 93%. And wound healing rate is excellent in what are complex and frail patients with multiple comorbidities at over 80%. So the encouraging 6-month outcomes have been maintained out to 12 months. And in that, I will finish. I would just like to thank my Prestige investigators and collaborators. This is obviously a team effort of which otherwise this could not be possible. Thank you very much for listening.